again. Thank you very much.
Thank you, Dr. Tugan, dear friend, Dr. Next speaker will be Dr. Manar Maamoun, our active speaker in the Egyptian Society of Radiology. The title is Post-Operative Assessment of Skull-Base Defects. Fortunately, it will be a chance to announce for the next scientific day for the Scientific Society, Egyptian Society of Neuroradiology. It is a branch of the Egyptian Society of Radiology. It will be here in Triumph Hotel on 17th of October in this year, hoping to join this society as a membership with SAMR and also as a speakers and attendee. Please, Dr. Manar.
Good afternoon. I'll talk about the expected post-surgical reconstruction of skull-base defects. First, skull-base imaging is usually a complex process because of the extensive changes to the normal anatomy and the evolving nature of the normal post-operative tissues. The aim of this lecture is to be familiar with the expected post-surgical imaging appearance of skull-base defects to provide adequate reporting and to avoid misinterpretation of an expected finding with a recurrent or residual defect or misinterpretation of an expected enhancing soft tissue for being a residual tumor after excision of skull-base tumors. There are several causes of for skull-base defects. My scope is spontaneous causes, traumatic, and iatrogenic causes, whether being accidental as during functional endoscopic sinonasal surgery or induced defect as a part of surgical or endoscopic intervention. Why should we treat skull-base defects? The presence of defects provides a ascending route for meningitis with a high mortality and morbidity rates. It also can be a source for pneumosyphilis, and it might result in CSF leakage if there is a combined bony and dural defects resulting in a connection between the subarachnoid space and the tympanomastoid cavity or the sinonasal cavity. The target for repair is absence of post-operative CSF leak and restoration of the barrier between the sinonasal mucosa or the tympanomastoid cavity and the subarachnoid space to prevent ascending infections. There are several available methods for skull-base reconstruction. The choice of the proper technique depends on the location of the defect, as there is a suitable method for each side of skull-base defect, and there are other determining factors, include the defect size, with smaller defects being easier to treat, and the choice depends also on the CSF flow rate, whether high or low flow. High flow means that there is a communication with the ventricle or cistern. First, I'd like to get sure that you are familiar with the known terms used for describing the site of the graft placement, include either underlay graft that lies entirely on the intracranial side of the defect, either in the epidural space or intradural, and the other term is overlay graft or onlay that's applied within the sinonasal side of the defect. Back to the different techniques for skull-base reconstruction, starting with the avascular graft, the most simplified method, either applied in a single layer or multi-layer avascular grafts. These grafts could be simply a fat tissue or fascia lata or an osseous graft. This is a case of repair of left cribriform plate of ethmoid encephalocele, showing an osseous layer which is taken from the mastoid bone and a mucosal layer. On follow-up, after 6 months, there is a progressive new osteogenesis of the bony graft. Here is another case showing repair of the left tegment tympani defect with a bony substitute. And this case showing the expected low density of a fatty graft in CT images, and its expected high T1 signal intensity in non-fat sat images. So it is essential to review the non-fat saturated T1 images in skull-base imaging. Another example of fat graft for cellular defect, an example of a multi-layer non-vascular graft skull base reconstruction with fascia lata that appears as a hypointense T2 signal intensity structure and an abdominal fat graft placed on the nasal side. General points for non-vascularized graft. The non-vascularized graft do not show enhancement in the early post-operative period. They take a while to grow vasculature and show post-contrast enhancement. Initially, there is a post-operative edema, so they show an expected high T2 signal, but later on, they undergo fibrosis, and there is a gradual loss of signal in T1 and T2 weighted images. Moving to another more complex method for repair, using intranasal vascular flaps. The most commonly used one called the nasoseptal flap, which has another term called Haddad flap. It's a mucoperiosteal and mucoprecondylar flap based on nasoseptal artery taken from one side, or in some cases both sides of the nasal septum, and rotated to cover the defect. Most of you will be familiar with this type of flap noted after transsphenoid resection of pituitary tumors. The nasoseptal flap is placed on the intranasal side of the defect as a layer of within skull base reconstruction. It includes also other layers of avascular graft. You can recognize the nasoseptal flap by its characteristic C-shaped appearance in sagittal and coronal images and initial post-contrast enhancement because it's a vascular flap. There are other layers I'll mention later, and we can trace the vascular pedicle in early post-operative imaging going to the sphenopalatine foramen. The layers from cranial to caudal in this reconstruction include intradural fat graft, then a thin layer of non-enhancing dural graft. It could be a new dura or a synthetic dura or fascia lata. Then the enhancing C-shaped appearance of the nasoseptal flap, followed by fat placed within the nasal cavity, and all held together by a surgical sponge within the nasal cavity. Sometimes they place a Foley's catheter to hold this in place. Again, the layers from cranial to caudal appear in early post-operative period. Later on, the differentiation in between different layers diminish, and we can notice the C-shaped appearance of the graft of the flap in coronal and axial images. MRI finding at 6 months, the flap acquire higher signal in T2 weighted images. In immediate post-operative period, the nasoseptal flap is the only enhancing structure within the layers of skull base reconstruction. Other layers as fascia lata and fat are non-enhancing structures. Later on, the fascia lata acquire post-contrast enhancement because it's a vascular graft that develop vascularity by time. We can also notice the retraction and loss of volume of the nasoseptal flap by time. Another case showing intradural fat placement, then the fascia lata, then the nasoseptal flap, and on follow-up study, the fascia lata show post-contrast enhancement and higher signal in T2 weighted image with retraction of the nasoseptal flap. The general reach of the nasoseptal flap means the areas that could be covered by this type of flap. This flap couldn't be done for posterior wall of the frontal sinus or the posterior 1/3 of the clivus, and also not done for the lateral orbital walls. Post-operative contrast MRI showing another type of less commonly used flap, which is the middle turbinate flap. Here you can notice absence of the middle turbinate, and there is an enhancing structure covering the osseous defect at the right cribriform plate of ethmoid, which is a placed or displaced middle turbinate flap. We can trace the pedicle of the middle turbinate flap, which is called the middle turbinate artery. Moving to another method of vascularized flap, or another type, which is called regional vascularized flap. The most common is pericranial flap, which is used for anterior or cellular defects when nasoseptal flap is not available. Pericranial flap include galio-pericranial tissue taken and folded inwards to cover the defect. This process includes cranialization of the frontal sinuses. By cranialization, I mean that you will find an expected post-operative finding. There is absence of the posterior wall of the frontal sinus, and the mucosa is surgically removed, and the cavity is obliterated. This flap is pliable and able to cover larger defect compared to the nasoseptal flap, so it's commonly used. This is the expected CT appearance of normal functioning pericranial flap with a soft tissue sheet or layer covering the skull base defect, and it appears also in non-contrast enhancing sagittal T1 weighted image. On T2 weighted image after 1 month from the operation, we can differentiate a 4-layer alternating hypo and hyperintense appearance on T2 weighted images called dark, bright appearance. The first dark layer represents the synthetic dura or fascia lata. The second hyperintense layer is actually the loose areolar tissue of the pericranial flap. Then a hypointense layer, which is the fibrous pericranium, which is a part of the used flap. Then the most caudal hyperintense layer represents granulation tissue or mucosa. This appearance do not appear in the first or initial imaging before 1 month after the operation. This flap can have variable thickness on T2 weighted images. Usually, the main bulk of SASIC flap comes from the layer of the loose areolar tissue. All this appearance and the variable thickness are normally functioning flaps. This is a diagram showing reconstruction of anterior skull base defect using inlay and onlay fascial graft and vascularized nasoseptal flap. And this diagram showing the appearance of the pericranial flap. And this is a reconstruction of the clivus using a nasoseptal graft, nasoseptal flap, but there is an additional layer of adipose tissue placed in between the fascia lata and the nasoseptal graft because this is a risky area with a high CSF pressure owing to the prepontine cistern. Double flap reconstruction could be done. This is a case showing the use of pericranial flap with expected appearance of anterior craniotomy and the use of nasoseptal flap because of a very large defect. Another flap called temporoparietal fascia flap used for lateral skull base reconstruction. It's pedicle on the superficial temporal artery, including the temporoparietal fascia and temporalis muscle, which are taken then rotated through a zygomatic arch osteotomy to cover a lateral skull base defect. This is the expected muscular appearance of the temporalis muscle with a striated pattern and post-contrast enhancement. And it's a vascular flap, so it will show initial post-contrast enhancement or early post-contrast enhancement. It also shows a multi-layering appearance on T2 weighted images with alternating hyper and hypointense layers. General points for vascular flap: the fat component of the flap can be easily identified on CT. Other soft tissue components are easier to be identified on MRI because of its soft tissue contrast. The flaps gradually lose volume due to edema resolution and muscle atrophy development. Free and regional flaps are recognized by their characteristic striated muscle pattern on MRI. The muscle component may undergo denervation atrophy, so it could show initial high signal intensity in STIR and T2 weighted images, then gradual increase in T1 signal intensity owing to the fatty infiltration. The pedicle flap starts enhancing immediately after the operation. Complications. One of the complications is flap displacement that causes recurrence of CSF leak. In this case, we couldn't recognize the appearance, the C-shaped appearance of the enhancing nasoseptal flap. And it is supposed that this enhancing tissue correspond to the displaced flap. Another example for graft displacement, supracellular fat graft displaced cranially, compressing the optic chiasm, and you can notice pneumosyphilis as a sign for recurrence of the skull base defect. There are complications specific for each type of flap. For example, in nasoseptal flap, it can cause septal perforation, nasal dorsum collapse as a donor site complication. And there are complications related to the initial condition as tumor recurrence that should be differentiated from the expected normal appearance. This table summarize the MR imaging evolution of the different grafts and flap on postoperative follow-up. Thank you.